22 years in a row, Americans have rated nurses as the most trusted profession, and there's a need for more of them. There are projections. The nursing field will grow 6% in the next 8 years, faster than the average for all occupations, but nurses face daunting challenges.
We keep hearing the word resilient and that we need to make people more resilient. I don't know how you make a nurse who has experienced 17 deaths in 7 days more resilient, but we have to look at the work environment and how, nursing is inherently stressful, but when we have more deaths and more bad outcomes, that does take a mental toll on any human.
Our guest today is the president of the American Nurses Association, Jennifer Mensik Kennedy. Dr. Mensik Kennedy earned her Ph.D. in nursing from the University of Arizona and also holds an MBA in healthcare administration.
We know the likelihood of healthcare workers being exposed to violence is higher than prison guards and police officers. So with 1 in 4 nurses having been assaulted at work. And we know that 29% of nurses in a survey have said they have faced violence in the last year.
This is Conversations on Healthcare.
ANA President Jennifer Mensik Kennedy, welcome to Conversations on Healthcare.
Thank you. Thank you for having me.
And congratulations. We read that Modern Healthcare recently recognized you as one of the 100 most influential people in healthcare. So our congratulations.
Thank you very much. It's a privilege to have that.
Yeah, we have lots of issues to ask you about, and we're looking forward to this conversation. Let's start with workforce. There's a recent survey by the American Nurses Foundation found that 90% of respondents say that staffing shortages at their organization is a serious problem. I wonder if you could just share with our listeners, what are the challenges nurses are facing in terms of staffing shortages?
No, absolutely. This is really important. And I think one of the important parts to know is that we had staffing challenges before COVID. And so these are not new issues, but these issues became so much worse during COVID when we had some higher turnover. We had nurses going into traveling positions because what was occurring was nurses were looking for some work-life balance. They were looking to have, they needed time for themselves. It was a very, very stressful time. Mm-hmm. And so while some organizations have recaptured some of those nurses that have left, they're still at much higher from a turnover perspective than we saw pre-COVID.
Well, Jennifer, you have some data that I think is actually maybe well known within nursing, but not so well known in the public about what happens when there's inadequate staffing, and particularly in the acute care setting, the ratio of patients to nurses. And I believe that your data shows that when we exceed what has been determined to be the ideal ratio based on the complexity of the patient and the setting by even 1 additional patient, that the chances of a patient actually dying within 30 days of hospitalization increase by 7%, and that those odds double if you increase that same ratio by 2 patients. Yeah. This, it seems, should be at the top of the headlines on a daily basis. But how do administrators and lawmakers react when you share these details with them?
No, I think people are concerned and really want to do something about that because, as you noted, for every single additional patient, the likelihood of you dying within 30 days of leaving the hospital increases by 7%. Of course, if a nurse had 3 additional patients above that safe level, each patient within that group has a 21% increased likelihood. So that continues, to escalate. And so there's a lot of stressors on, from an organizational perspective that says, well, where are we going to get these nurses? But how can we, keep nurses if we continue to have short staffing in these organizations? So we really do need to focus in on items, the environment of those organizations where nurses, one, want to stay in those environments and work in the hospital, and then also be able to provide the appropriate level of staffing. So we know that organizations can get down below, between a 5 and a 10% turnover rate, which is much lower than a 21% turnover rate. if we focus in on the work environment, such as staffing committees, shared governance, listening to nurses' voices are so important. And then also being able to provide assistance in other areas. Quite often when we start looking at hospitals and they start cutting resources, that the nurse is the one that ends up providing housekeeping services, some of the dietary services. And so nurses end up taking on the workload of a lot of other disciplines when we really need the full approach. So not only do we need more nurses in the hospital providing care, but we also need the team around them to support the nurses so that nurses can do what nurses do best, and that's provide nursing care and not provide, overburden them with a lot of things that it doesn't take a nurse to do. So I think we need to really focus in on that work environment, being able to make sure there's enough nurses, and then providing that supportive team to help make sure the patient gets their best quality care.
All right, I'm going to put my patient hat on and consumer hat on. Scared the heebie-jeebies out of me. Should I be asking the nurse how many people you're taking care of? How would I know if they've got one or two more? How do you empower me in terms of figuring out, is this, you've got 3 extra people and I'm getting out of the hospital right away.
And you're worried about it. So I think I think patients and family members should be empowered to ask these questions. And what we've seen, because this has become, we've been working on this for decades, we haven't really seen big improvement. But what we saw this last year was there were 19 states that have, started to look at legislation within the state level. And in some states, for instance, like in Illinois, there's mandatory posting a requirement for each unit. So if you walk into a hospital unit, it actually tells you the number of RNs on that unit for that shift. So I think from a consumer perspective, as a patient, it is perfectly fine to ask, how many nurses, how many RNs are on this unit today? And even supporting legislation that helps provide that transparency so that as a patient, the organization, what's going on. And I would continue to if you can, participate or attend hospital and healthcare board meetings when they have open board meetings. It's really important to provide that feedback on patient surveys that says, we really need to work on this. So from a safety perspective, it is really important for us to also engage the patients and families in this.
Let me just follow up with a question around when there's conflict that happens within the hospital between administration and nursing. You recently were interviewed by the publication Chief Healthcare Executive, and you said you see the potential for strikes in the near future. And we noted that last year there was a strike in New York City that lasted 3 days. I'm wondering, from your vantage point, how effective are strikes, and when do you think they're the best option?
No, nurses want to do the best for their patients, and they want to provide the best patient care. And striking is usually always the last resort any nurse wants to take. And so this isn't something that they would do from a first perspective. Often when nurses do vote to strike, this is something after months of work and partnership and being at the table, and things just didn't come to fruition between them and the hospital or the administration. So nursing strikes are always a last resort after every other avenue has really maybe deteriorated.
Well, Jennifer, I think across our society and in many professions, disciplines, work groups, resiliency, wellness, and its counter, burnout, despair, mental health issues are everywhere. But I think it's shocking that the American Nurses Foundation survey found that 56% of nurses say they're experiencing burnout, and that's manifested in exhaustion, work frustration. And 2/3 of those nurses surveyed said they're not getting any support for their mental health. What more can be done to help on this front, either within the institutions or within the profession generally? Does the American Nurses Association have any initiatives going in this area?
No, absolutely. This is a great question. And I think this goes hand in hand with the staffing issues. When nurses don't get those resources, they do they feel like one of their only options is to maybe take a break from employment, leave actually the nursing workforce, or take a long break. And we need to look at how we staff and those organizations and the attributes in an organization that really support a nurse's well-being. And so things such as mandatory overtime, we have organizations that basically say, we are going to make you pick up an extra shift. Regardless if, and that's beyond their 40 hours a week. And so what we found is nurses on average work more hours than most Americans in other professions because of this mandatory overtime. So we really need to look at how that plays out. And then also so we're looking at, what does that look like from a legislative and a regulatory perspective? And I would also put out the American Nurses Foundation has a large toolkit of resources, such as the Wellbeing Initiative. And the Wellbeing Initiative is for any nurse, whether you're a member or not, can go in and take a confidential survey to look at your well-being. And there's a lot of free resources for nurses to be able to do on their own time in the privacy of their own home, to be able to help them with their well-being. A lot of organizations maybe have a well-being program, and I think they need to maybe market it more or provide it so that nurses and other healthcare providers can really access those services. I think one of the detriments is we keep hearing the word resilient and that we need to make people more resilient. And I don't know how you make a nurse who has experienced 17 deaths in 7 days more resilient, but we have to look at the work environment and how, nursing is inherently stressful, but when we have more deaths and more bad outcomes, that does take a mental toll on any human, regardless of how resilient you are. And so there's a lot more to, resiliency training, because nursing is just a different field. We want to care for people, and we need to be able to also care for ourselves. And so remember noting to other nurses, the code of ethics for nurses says you need to take care of yourself as well so that you can take care of others. It's like the safety video on a plane that says, put the oxygen mask on yourself first before you help others. And we really need to help nurses do that so that they're well for others.
Mm-hmm. I want to just connect the dots between the regulatory issues and the well-being issues you were just talking about. I think most of our listeners know that licensing for nurses happens at the state level, and we've seen that about half the states have dropped questions about mental health from their licensing questions for physicians. I'm wondering, do you think they should also drop those questions on nurse license applications?
Absolutely. What we've seen is we had, I believe, one state this year actually add the question on their renewal. I just renewed my license in Oregon, and the same question appeared. And it is a detriment for nurses who think, what if I do answer yes? What's going to happen? And why do we need to know that question? And I think about that as that's a barrier. If I needed mental health services, that, my license is my livelihood. And so we know nurses particularly have a higher rates of suicide. So why are we creating unnecessary barriers when people might fear having their license taken away, that they don't get the treatment and then end up actually suicidal because of that. So we really do need to remove all of those questions from those licensing pieces. And also from a federal level, we need to reauthorize the Dr. Lorna Breen Act. It was funded in the last Congress. We need to refund it again. It's going to provide money and resources for organizations at a national level to be able to address this issue of provider and nurse suicide.
Well, Jennifer, thank you for shining a light on that legislation. That was a very sad story from the COVID era, which I'm sure many of our listeners are familiar with. But I want to talk about another very sobering thing. We're going to talk about optimistic and positive things sometime before we get through the end of the show. But in all seriousness, this is a real problem. 2 nurses per hour are assaulted in the acute care setting. And I might add, though we're going to focus on the acute care setting right now, this is also a problem in home care, long-term care facilities, public health. Nurses are often at risk. How is ANA responding to this? And is this something that needs to be addressed on the federal level by CMS, or is it really up to the state legislatures to address it? Share your thoughts on and what's going on that level.
Absolutely. So we know the likelihood of healthcare workers being exposed to violence is higher than prison guards and police officers. So with 1 in 4 nurses having been assaulted at work. And we know that 29% of nurses in a survey have said they have faced violence in the last year. So I think what we need, and what I've seen, is we have work going on at a state level and a federal level. At a federal level, the American Nurses Association has the Workplace Violence Prevention for Healthcare and Social Service Workers Act. And if this is passed, this legislation would require OSHA, the Occupational Safety and Health Administration, to develop and enforce specific standards for healthcare and social service employers to hold them accountable for protecting their employees. I've seen some local state level legislation where increases the fines, makes it a felony, for instance, to assault a healthcare worker. However, so while those are good, it doesn't prevent it from happening. We would rather not see the violence or the assault happen. So how are we really working to prevent it in a healthcare setting? So that's why we really focus in on prevention in the federal bill. But we have states working on it locally to do the same thing, whether it's making it a felony or working on how do we figure this out from a preventative perspective.
Margaret, I know our good friend, Representative Joe Courtney, has been big on this issue, been a strong advocate of that, and we'll certainly keep an eye on this important piece of legislation. I want to talk about the ANA's readiness and responsiveness. We hear this troubling statistic that 63% of nurses say they have personally experienced an act of racism in the workplace. And I'm wondering if you could share with our listeners ANA's journey on racial reckoning and its important national commission to address racism in nursing. How are they making a difference? Tell us more.
Absolutely. Thank you. So, the American Nurses Association has recognized our own role and our past actions that have negatively impacted nurses of color and the perpetuated systemic racism. And so we are taking meaningful and historic action to begin a journey of racial reckoning. And so what we know is there was a period of time where the American Nurses Association did not allow nurses of color to be members. And so we have a lot of work to do to really reconcile our own history. We are, as you noted, the one of the co-leads to the National Commission to Address Racism in Nursing. And so when we look at this, we have seen individuals say that half of our respondents in surveys said there is a widespread racism in nursing issue still today. And many respondents, so across the Hispanic, Asian, as well as other communities of color, have reported personal experiences in the workplace of racism. And what we find is that Black nurses are more likely to personally experience and confront acts of racism. And so we are really focusing in on education, as well as steps to be intentional on being an ally and what allyship means in nursing. And additionally, we are coming out with a 4th series on what we call Project Echo on racism in nursing, which is starting March 6th. And this is an 8-part interactive series that explores causes of racism, identifies strategies for taking action towards health equity. But what we're also doing is that we have position statements on DEI and really and speaking up when we see our federal government and other state level organizations pushing back on implicit bias or DEI activities. We have a position that says this is really important because we can't be nurses and take care of people if we don't address racism. Every person deserves the best healthcare. And we also need nurses that represent the populations and the communities that they serve. And so another another way we need to address this, and we're working on it, is nursing has been traditionally female and white. And so increasing more males into the profession, increasing other races into the profession, so that we do reflect a society at large.
Well, Jennifer, I know you're challenged to take strong positions and put your voice out there on behalf of the profession. And one that is fairly recent, I think, is that you've challenged a new American Medical Association policy amendment recommending that advanced practice registered nurses, commonly known as nurse practitioners, clinical specialists, nurse midwives, be licensed and regulated by both state medical and nursing boards. Tell us about that. Is that a recent amendment? That would seem like turning the clock back a few decades.
No, absolutely. And definitely this is a more recent activity for the American Medical Association. However, from a state perspective, there are still many states that do not allow full practice authority for APRNs, and those state level medical associations continue to fight and push back. We, from a regulatory and licensing perspective, we are not going to license and oversee medical. And these are advanced practice registered nurses in their title. And so they are advanced practice of nursing. And so we need to be able to continue to oversee them from a nursing perspective. Every APRN is a registered nurse with their additional education and certification, residencies, and clinical hours. And so we need to continue to oversee them. Now, we know we've had decades of studies that show that APRNs, nurse practitioners particularly, provide the same quality patient outcomes and care as do primary care physicians. Additionally, and this kind of gets into AI, as we see AI technology in the future, this really changes the dynamic and provides a different perspective of care. Again, further, reiterating the need for not having additional regulations and licensing and barriers. We have too many communities who do not have primary care providers, and APRNs are those individuals. So why would we continue to put additional barriers for patients getting timely care in a time where we just have too many shortages of all providers, when we know NPs are safe and can provide quality care in the communities, particularly rural communities where physicians may not be?
Over the last decade and a half, we've seen states legalize cannabis and marijuana, and that's been a big sea change. It hasn't happened at the federal level, but it's happening at the state level. And we noted with interest that in September, the ANA formally recognized cannabis nursing as a nursing specialty. And I'm wondering, why did you push for this, and what benefits does it provide to nurses and patients? And I'd also maybe pull the thread a little more and say we're seeing the intervention by Veterans Affairs on managing with ketamine post-traumatic stress disorder. We're seeing a whole new area open up. So tell us about at least the nursing side and maybe other broader thoughts that you might have in this area.
Absolutely. It was fun to see the worldwide response to that position statement. I think I got more traction on that position statement than sometimes anyone else, any other statements. And it's important because people are doing this. They are utilizing marijuana, whether it's recreational or for medicinal uses. And as a nurse, you need to be able to assess that patient, but also understand how that might, why they're using it, and then how it also might impact other medical or nursing or healthcare treatments that patient is getting. So it's part of the patient. And when we don't focus in and understand how that might interplay with other healthcare pieces, we're really ignoring a very vital part of that patient. And that could actually lead to bad outcomes outcomes if a patient was to go to surgery or to take other medications. So it's really a part of the patient, and it's important for nurses to be able to understand that. But there's also a specialty piece to that, especially with the work that the VA is doing. So it's really recognizing that this is a special area of knowledge that nurses can hold and really hone in on to help people who are maybe looking at it from a medicinal use perspective, to really help them get the solutions and the outcomes they're looking for. And so I'm glad to see that we're moving that direction. And I think it's just a matter of time before we have federal change, particularly. And most importantly is we do need research and continued research in this area. As it's become legal in different states, we've seen more research, and I think that's just going to help us understand so much about the use and why people are using it and those interactions. So we need to continue. It's not going to go away, and I don't think it's served us well to have ignored it for so long in society.
Well, Jennifer, ANA is leading the way through a number of initiatives to bring attention to the role of nurses in care coordination. And of course, nurses have always been engaged in care coordination and in all settings. But in our era of value-based care and population health, this has taken on a whole new importance. We can do remote patient monitoring of the patient in their home, the transitions between hospital and home and community, et cetera. But you're also asking for payment for these essential services as a distinct component of patient care, and I think payment to nursing for nursing services. This will be a big lift. What are you doing to overcome the hurdles to this goal, and where is CMS on all of this?
Absolutely. This is great questions. And so we are working this year actually on a multi-pronged strategy, one of which is bringing together a group of stakeholders, academics and experts, expert leaders in this area in April to really look at the economic model of nursing and to be able then to put that out for use and consumption. We've also, from the American Nurses Foundation perspective, we have the Reimagining Nurses campaign, and we've actually provided multiple millions of dollars to numerous projects that are focused in on looking at nurse reimbursement in various settings. And these are items that we believe are scalable, that have the ability to move to other organizations, such as looking at the work of nurses in the community for patients that who may be between healthcare settings, be between primary care providers, and really need that connection, whether it's between after a hospitalization, getting into the clinics, or just management of their chronic disease. What happens now is if a nurse does work in a clinic, that their care, we don't know what nurses do because we don't have our own NPI number. We can get our NPI number. And what's one of the things the American Nurses Association is asking every RN and every APRN to do is get your NPI number, National Provider Identifier, so that when we do something such as care coordination, education, teaching, management, chronic disease management, we can put that down on the bill so that our number is attached to that. So as it is now, typically the physicians will account for it and it'll roll up to them so that it looks like the physicians are actually doing these activities when it truly is in fact the nurses that are doing these activities. So one of the pieces is just saying we would just like credit and recognition for all the things we do. I think a lot of times people know what nurses do in a sense, but don't realize the extent at which we are doing care coordination activities across the board. And so being able to attach what's in the electronic health record to what's being billed on our behalf, even though we never see that, I think is really, really important. And that's the first step in being able to say, here's the value of that nurse in the clinic or in the community or even in a hospital. For instance, nurses are in the bed charge in a hospital. So in the the room rate. And so we have everyone outside the room rate. And so it's really important to be able to say, this is the portion that's nursing care. And when it's in the bed rate, it's easy for administrators and finance individuals to, move that money around because you don't really see the impact from a nursing perspective. So that's another component, is being able to say, we don't want to be in the hospital room rate any longer. We want to be pulled out or recognized separate, so that you can see that this is what you're being, this is what nursing time is for you when you are in the hospital as opposed to being the bed charge. So those are several of those pieces that we're looking at doing and focusing in on.
Jennifer, you're ANA president. How did that come about? Tell us a little bit about yourself.
So thank you. I never would have in a million years thought I would have been ANA president. I did decide I wanted to be a nurse when I was in high school, and I have been a nurse my entire life. And, the great thing about being a nurse is when you get your nursing degree, there are so many possible things that you can do with being a nurse. And I really do like change and making change happen. And I don't like to complain unless I'm going to do something about it. So I think that's how it got me involved. I got involved at my local state level nursing association. And then it kind of just evolved from there, where I decided to run and be involved at a federal level with the American Nurses Association. And here I am today as president.
Well, we're very glad you are. ANA President Jennifer Mensik Kennedy, thank you for joining us, and thanks to our audience for being here. Be sure to subscribe to our videos on YouTube, find us on Facebook and X with our account name CHC Radio. As always, you can go online to chcradio.com, sign up for our email updates, and also please share your thoughts and comments about this program. Dr. Mensik Kennedy, thank you so much for joining us today on Conversations on Healthcare.
Thank you.
This copyrighted program is produced by Conversations on Healthcare and cannot be reproduced or retransmitted in whole or in part without the express written consent from Community Health Center, Inc. The views expressed by guests are their own, and they do not necessarily reflect the opinion of Conversations on Healthcare or its affiliated entities.